All right, let's get started with heme. Welcome everyone, thanks for coming. Yeah, as usual, if you have any questions, leave them in the chat. And yeah, let's just get started. So I'm taking care of physiology. We're going to cover the cancers in the next session, as well as immunology in the next session. But otherwise, heme is basically all physiology. And then you attach some pharmacology and some like pathology onto that. Yeah, so the way I'll set this out is we're going to go through hematopoiesis and then we'll go through cell by cell. So we'll cover red blood cells first, including things like anemias, blood grouping, everything like that. And then we'll go on to like platelets, clotting, things like that, and then white blood cells. And then we'll look at a few investigations and blood films and things like that. So hematopoiesis is just how you make blood cells. So you're making 200 billion cells a day, and when it's in the bone marrow, which is most of it, once you're out of the womb, you call that medullary hematopoiesis. And medullary often just kind of means bone marrow. If it's outside of the bone marrow, then it makes sense to call it extra medullary hematopoiesis. I think the main takeaway from this would be this whole picture would be that prenatally, you make a lot of the blood cells from the yolk sac, and then the liver and spleen kind of take over, and then finally in the last few months bone marrow will take over, and then it does so for the rest of your lives. Aplastic anemia, I don't know where to stick this, so I stuck it at the front, but we're going to go through two causes of pancytopenia. So penia means reduction, and pan means all, and cyto means cell. So all cells are reduced. Aplastic anemia is when that's due to bone marrow damage, because we see that it's most of our hematopoiesis in the bone marrow. The important thing about this isn't really the causes, but the fact that you see everything decrease, including reticulocytes. And we'll cover that a little bit later, but reticulocytes are immature red blood cells. And it's important to differentiate that because you can also get pancytopenia, or like you can, from like no EPO, so renal impairment. But not pancytopenia, sorry, you can get low reticulocytes with no EPO, because that's the thing that makes your red blood cells mature, basically, and that's made in your kidneys. But aplastic anemia will also have reduction in other cells, so neutropenia, thrombocytopenia, things like that. Cool. Diagnosis is just bone marrow biopsy. So you can see here, we'll go over this a little bit later as well, but you don't really see any cells. It's mostly fat, which is really abnormal. Myelodysplastic syndrome is quite niche, but essentially it's just a group of clonal HSC cells. And so you get like, and that means hematopoietic stem cells, so your first progenitor. And so because of that, you get peripheral pancytopenia, because everything comes from that cell, and that's how it presents. And you can get hypercellular or hypocellular bone marrow, depending on whether that's proliferating a lot, making it hypercellular, or whether that's like pushing a lot of cells out, making it hypocellular. And this can progress to AML, which we'll cover tomorrow. Nice. So this is your blood components. 50% is plasma, so that's the fluid. They once asked us an exam question on what plasma proteins include. So you have albumin, you have globulins like clotting factors, you have immunoglobulins, so your antibodies, and you have fibrinogen, which is also part of clotting. You have 45% hematocrit, so that's just red blood cells. And then you have less than 1% of like a Buffy code. So that's like your platelets and leukocytes. So that's all of these guys here. So I'll go through this really quickly, but basically this is how you get all of your cells. I really like this picture. I know there are better quality pictures, but I like how this one summarized all the cells. So you start with your hematopoietic stem cell, so your HSC, and that goes into either a lymphoid progenitor or a myeloid progenitor. And I think the easiest way to remember what cells come from which is to just remember which one's a lymphoid, and then everything else is from your myeloid. So lymphoid sounds like lymphocytes, so it makes sense for your B cells and your T cells to come from your lymphoid progenitor. Your NK cell also comes from your lymphoid progenitor. And you know that because it kind of works in the same way as your B and T cells, which we'll cover again with Kevin. And also you can get dendritic cells from both of them. And then everything else is just your common myeloid progenitor. I think it's also worth noting that megakaryocytes, which form your platelets, and erythroblasts, which form your erythrocytes, kind of come from the same progenitor. So sometimes when you get decreased red blood cells, you also get decreased platelets, and that's because it's working somewhere there. And also another thing to note is that in your blood, you have monocytes. If they move into your cells, then they're called macrophages. So they're actually the same kind of cell. So these are your HSCs, your hematopoietic stem cells. They're multipotent, they're self-renewing, they're able to pause themselves, so they stop kind of reproducing, and they don't die. Erythrocytes. So they're just your red blood cells. You have a little bit of like what they look like. So they're 2 micrometers thick, 7 micrometers in diameter. I don't think you have to remember that. Remember that they're disc-shaped and concave on each side. So they go in, and mature red blood cells have no nuclei. Almost the entire volume is instead taken up by hemoglobin, and that's made up of 4 globins, 2 alpha, 2 beta, each with a heme unit. And in the heme unit, which is this little blue thing here, contains like an iron, which is held by a cyclic ring of nitrogen, and that's where oxygen binds. So you can see that each hemoglobin molecule can carry 4 oxygen molecules. So yeah, red blood cells are essentially just little bubbles of hemoglobin. Erythropoiesis happens in the large cells of bone marrow of certain bones, and they have a lifespan of 120 days. That's something to remember, that always comes up. And regulation, as I said before, by the kidney secreting EPO. And yeah, that's about it. So when you have decrease in red blood cells, you get anemia. And that presents usually pretty non-specifically. People get tired because they're not getting enough oxygen to like your body tissues. You can get palpitations, tachycardia, so like your heart's pumping harder to get it everywhere. You can also get like dyspnea, so you're breathing more because you're not really getting oxygen places. And because you're not getting oxygen places, that ends up, you can affect your brain, so you can get headaches, confusion, you get pallor because red blood cells, and yeah, that's about it. The way to diagnose it is with an FBE or a full blood count, and that'll show that your hemoglobin and hematocrit, which is your red blood cells, are low. If other cells are also low, consider aplastic anemia, like we mentioned before, and you treat the underlying cause. So we'll go through the causes now. You sort them into 3 groups, essentially. So a normal mean corpuscular volume is 80 to 100. Hi, Gavin. And so anything under that, anything under 80 would be microcytic. Anything that's between that is normocytic, and anything over 100 would be macrocytic. So the causes of microcytic anemia, you can use TAILS, so thalassemia, anemia of chronic disease, iron deficiency, lead poisoning, sideroblastic. Another way you might remember this is like thalassemia is when you like don't have enough hemoglobin, so it's going to make your red blood cells smaller. And then like iron as well as in your hemoglobin, so it's going to make your red blood cells smaller. And then normocytic, you can remember with ABCD. So acute blood loss, because you're just bleeding out, there's nothing wrong with your blood cells. It's going to be normocytic. Bone marrow failure, so you're just making less. Chronic disease again, and then destruction, so hemolytic anemia. And that's because, again, before they were destroyed, essentially, they were normal. Macrocytic anemia, you can use fat red blood cell. So fetus, so pregnancy, alcohol, thyroid, which is hypothyroidism, reticulocytosis, so that's when you have too many immature red blood cells, and that's because reticulocytes are naturally just bigger than red blood cell, like mature red blood cells. B12 and folate is important. Deficiency, cirrhosis, so liver problems, and then you can also add drugs, phenytoin, metformin, methotrexate. B12 and folate is also megaloblastic, and that just means that your neutrophils also have lots of nuclei, so they're multinucleated, more than normal. I think it's more than 5. So yeah, these are the normal ones. You at least have to remember these ones, but they're not too hard to remember, and it's a very common examination question. So we'll go through some of the microcytic anemias, mainly just iron. So iron is required for a lot of things. It's absorbed in the duodenum, which we covered a lot, and it's bound to transferrin in blood, transfer of ferrin, and it's stored as ferritin in cells, especially in the liver and spleen. So iron toxicity is possible, and it's usually due to children finding iron pills, but you can also get it if you have an inherited condition called hemochromatosis, and it's bad. Essentially, it's just bad. The treatment is to administer desferrioxamine, which is an iron chelator. So it binds iron in the bowel, so you can't absorb it. You can also get deferriprone, which is oral, and that makes it excrete in the urine. That's basically it. For iron deficiency, this is quite important. It's 30% of all cases of diagnosed anemia, and you can get it via increased demand for iron, so you're not having enough anyway with the normal amount that you're intaking. You can get it with chronic bleeding, because you're just bleeding out all your iron and your hemoglobin, and you can also get it via inadequate absorption. So increased demand happens in childhood, it happens in pregnancy, and if you give a lot of blood donations. Chronic bleeding can be due to a lot of things, but like heavy periods, menorrhagia, peptic ulcers, bleeding into your stomach, things like that. And then inadequate absorption, things like celiac, also like I guess you diet. So if you're vegan, like me, you might get iron deficient. Not like me. Presentation, you get glossitis, stomatitis, koilonychia, dry and pale skin. Pica is when they eat weird things like ice, I think, and like paper, and splenomegaly. Diagnosis, I'd say do iron studies first, of course. You'll see decreased serum iron and serum ferritin, and usually doctors will just look at the ferritin because that's indicative of all your iron stores in your body. And then transferrin will increase while transferrin saturation will decrease. You can do a colonoscopy to check the duodenum, see if there's anything wrong there, and blood film will show hypochromic microcytic anemia. So you know it's hypochromic because you have these like little bits in the middle, which is a bit pale and it's bigger than usual. So a little bit is okay, big is not okay. You can also get poikilocytosis, so that's cell differences in cell shape. Elliptocytes, which are like pencil cells, they're like long and oval, and anisocytosis, I hate these words, which is variation in cell size. Management is just give them iron orally. There are different ways you can give that, and if it's really bad, you can give it intramuscular or IV.
I think what's interesting to note about, I guess, the iron management and the iron replacement is that 100 to 200 milligrams per day for adults is a lot more than what you'd get in like the little chemist thing where you get like nature's own iron. So it's important to recognize that, I guess, more in real life than in, I guess, patients. But if a patient in your exam says they take iron, but it's like very little, that's not enough to do anything. And it comes back next year to be useful. And yeah, when you look at iron studies, the serum iron is useful for like random things that are like very weird. So like realistically speaking, they like hammered this into us last year, and it's useful for you guys this year anyway. So just take it as if it's read serum ferritin first, and then the iron serum level is just like whatever.
Yeah.
Yeah, I was just going to mention on the iron studies as well. Like, it didn't make sense to me until like this year, kind of where it all came together. Like the first two are decreased because like your overall iron was like less in your body, which makes sense, and then your transference increased because like your body thinks, oh, okay, there's not enough iron in the body. I got to make more of these molecules to like send out the iron molecules. But because they don't actually have enough iron molecules, there's actually less per transferrin molecule. So like that's kind of why things are like that.
Nice. Awesome. On to some macrocytic anemias. So alcohol and B12 and folate are important. B12 deficiency. B12 is an essential nutrient, so you need to essentially intake it. And in order to absorb it, you need intrinsic factor, which is produced by parietal cells in the stomach. And then it's absorbed in the terminal ileum, stored in the liver, and it stores for actually a long time. So it takes a while for someone to become B12 deficient. And for function, it's required actually for folate or B9 function and nerves. And so usually this is due to malabsorption. So pernicious anemia is when you have an autoantibody produced to intrinsic factor or parietal cells, and they actually examine this quite often. And because of that, you can't absorb it, so you get deficient. But also things like gastrectomy. So if you have no stomach, you also have no intrinsic factor, and things like IBD. Which can affect the terminal ileum, so that's making it difficult to absorb. You can also have inadequate intake, so vegans and vegetarians, if they're not supplementing, then they will most likely get B12 deficiency because it's only found in animal products and dirt, I think. So presentation is anemia, so lethargy, pallor, the usual. You can also get glossitis, but the big thing is neurological issues. So patients will be like tingling, they'll get, they could have numbness, there could be dementia, things like that. Fun story while we're here, when I was on the heme ward, there was a patient who spent $3,000 on NANGs, and he was found with like, many empty cans in his room. And what nitrous oxide or NANGs can do is it makes you B12 deficient as well. And so he came into hospital and he had like tingles all over because of the peripheral neuropathy. So if that helps you remember that story. Diagnosis is as usual. So FBC, or full blood count, or FBE, will show your normal anemic changes, low hemoglobin, and it'll be macrocytic. It's megaloblastic, so neutrophil hypersegmentation, which just means many like nuclei, so more than 4 or 5. You can get oval macrocytes, pancytopenia if severe, etc. Schilling test measures absorption of B12 with and without intrinsic factor. So that's just to find if you have pernicious anemia. And you can also confirm with elevated homocysteine, which is needed as a cofactor for B12 to work. Treatment is just supplementation again. So hydroxycobalamin is just B12 essentially. You give it intramuscularly. Pernicious anemia will require lifelong therapy, and if they're also folate deficient, don't give that alone. You always need to give B12 as well, because B12 is required for B9 or folate function. So this is folate deficiency. So the main points about folate is it's found in green leafy vegetables, yeast, liver, and kidney. It's absorbed in the jejunum and functions in DNA synthesis. And it requires B12 to function. Etiology, the big one here is chronic alcoholics. It's always a scenario about an alcoholic, basically. But you can also get it via like malabsorption or increased requirement in pregnancy and infancy, and 2 drugs that cause it, phenytoin and methotrexate, are quite big. Presents similar to B12, except you have no neurological features, and people get folate supplements in pregnancy because when you're deficient, it can lead to neural tube defects. Treatment, again, is supplementation. So you'll just have oral folic acid, 5 milligrams a day, and exclude B12 deficiency. Nice. So last one is normocytic anemias. And these are mainly your hemolytic anemias. This is kind of a long list, but I'd say these ones, like focus on these ones. For diagnosis, I'll go through the hemolytic screen a little bit later again, but you get increased LDH, increased bilirubin, because that's in your red blood cells, and it's made from heme, right? So you'll have increased unconjugated bilirubin. You have decreased haptoglobin. You have reticulocytosis because you're like breaking up all the cells, and so your body's like, oh, I have to make more, so you'll have more immature red blood cells, and it's also Coombs test positive. These are some of them. So, and it's kind of sorted by your blood film, but you get MAHAs or microangiopathic hemolysis. I wouldn't worry about these too much for this year. You can get hereditary leptocytosis, you can get spherocytes, you can get sickle cells, you can get G6PD deficiency, which you inherit, and then you can have like malaria essentially. But you can see with a lot of these that they're funky shapes, and that's kind of why it causes hemolytic anemia, because it's a funky shape. It gets destroyed essentially. So G6PD deficiency, so it's X-linked. G6PD stands for glucose 6-phosphate dehydrogenase, and essentially when you lose this, you become more prone to oxidative stress, and that causes hemolysis. And on blood film, you see these Heinz bodies, and what happens is basically, like, I guess you can remember like Heinz, like beans, like yummy. Macrophage comes and like takes a bite out of it, and it becomes bite cell. And so you see these two things on blood film. It's common where malaria is common for the same reason sickle cell disease is, and that's because like they find it difficult to like insert their eggs into the cells. And then presentation is mainly asymptomatic, but on an exam question, you'll see like fava beans or broad beans because it can trigger it. And once it's triggered, then they might get hemoglobinuria. So hemoglobin in their urine, so dark red or black urine. And you can also have prolonged or severe neonatal jaundice. So lots of the hemolytic anemia, well, like basically all of them, can present with jaundice because of the release of heme into bilirubin. Yeah. Treatment is avoid precipitants. That's basically it. Sideroblastic anemia is failure to produce heme. Nice. Thalassemia. These are when you have congenital alpha or beta hemoglobin chain deletions. It's common in Asians and Mediterraneans, and they have 3 syndromes. So if you just have the trait, then you're asymptomatic. Basically, if you have intermedia, then you can have intermittent hemolysis, and then if you have major, that means that 2 beta chains are deleted, and then that's when you get like the lifelong transfusion dependence. Diagnosis is via hemoglobin electrophoresis, so that's a big buzzword, I guess. And on blood film, you see microcytic hyperchromic cells. You can also see target cells and like different shapes and colors. Sickle cell anemia is when your red blood cell is shaped like a sickle, and it's autosomal recessive due to a missense mutation in the HBV gene. Don't really have to know that. Yeah, so basically, because these red blood cells turn into this shape, it can't hold oxygen properly, so you get anemia. And then this kind of shape also accumulates a lot in your blood vessels, and because of that, you can occlude your vessels and cause other issues. So you can cause dactylitis, which is digit inflammation. You know, avascular necrosis, strokes, hematuria, proteinuria, essentially a whole lot of issues due to sickle cell anemia. Diagnosis, you can have a newborn blood spot, but a blood smear, you'll see these guys. They'll just look like this, like that essentially. And you can also do protein electrophoresis for HB sickle. Management, you don't really have to know, but it's there. You can read it in your own time. All right, so that's anemia done. Go on to some other things about red blood cells. So one thing is blood groups. The most common in Australia is O+. The least common is AB-. And so the O and AB comes from your ABO blood type, and the plus and minus comes from your rhesus, so RH. So ABO blood types, basically what this is, I think the best way to think this through is kind of understand where it comes from, and then all the testing and all the antibodies and everything like that and all the issues will make a lot more sense. So on your red blood cells, you can have two types of antigens. You can have antigen A, or you can have antigen B, well named, or you can have both, or you can have none. So when you have A on your red blood cell, then your blood type A. When you have B on your blood cell, your blood type B. If you have both, you're AB, and you have none, you're O. And when you have an antigen on your red blood cell, you're not going to have antibodies to that antigen. And you can see that with AB, because you have both, you don't have any antibodies in your plasma, because if you did, it would attack the antigens on your red blood cell, and that would cause issues like hemolysis. And that's why also blood type B, which has B antigens on the cell, won't have B antibodies, but they'll have A antibodies. And that's why O, which has no antigens of the ABO, of the AB type, will have both of them in their serum. And all of these antibodies are IgM, so you can see that with the 5-prong thing, and it's all on chromosome 9. There are a few exceptions. Babies don't make anti-A or anti-B until a few months old. And during pregnancy, some of the mother's antibodies, which are in IgG instead of IgM, will be transported into the placenta. So rhesus groups, a little bit similar, except with ABO, if you're born with blood type A, for example, you'll always have the antibody in your blood anyway for B. Whereas for rhesus, which mainly is antigen D, if you're negative, you don't naturally have the antibody, which is an IgG, in your blood. And so what happens is you need to be exposed to the antigen once, and the first time nothing will happen. And then once you're exposed to it again, then you've produced the antibodies from the first time, and that will cause a reaction in the future. Yep, that's it. So these are blood grouping procedures, and they asked us quite a lot about this, quite frequently actually. And it seems difficult, but it's actually pretty simple. One cell typing or forward grouping, one serum typing or reverse grouping. So cell typing is when you take the patient or the donor's cells, and serum typing is when you take the patient or the donor's serum. So on each of these, you would test it with the opposite thing. So when you take the donor cells, you need to test it with serum because you can't test cell against cell. And then if you take the serum, then you need to compare that or like react that with cells that you know. So with cell typing, your patient cells are tested with antisera or just a serum that you know with antibodies for ABO or RH antigens. Agglutination is when this reaction happens, and that suggests it's positive on the cell. So for example, if anti-A is positive, so anti-A would be in the antisera, if it's positive and caused agglutination, then it means that the donor cell has to have the antigen A on the cell. Anti-AB would also be positive because that would also attack A, and hence the blood group would be A. Similar thing for B. For AB, it'll all be positive because A will attack the A on the AB blood cell, B will attack the B on the AB blood cell, and AB will attack both. And then on O, because they don't have anything, none of these antibodies will attack there are no antigens to attack. So it's just going to be all negative. And that's similar for the rhesus group. For serum typing, you're using the donor or the patient's serum, and you have blood cells that you know. And so when it agglutinates, it means it's negative on the cell. So for example, if you use A cells and it doesn't react, then it means, oh wait, I'm going to sort this out more very. Yes, then it means you don't have the antibodies for A, and hence you have the A antigen. Yes. With B cells react, then it means that if B cells react, then you have the antibody for B. And so that means that your cells don't have B. And so there's no B, essentially. It's a little bit like, but essentially it's just the opposite, right? So if you remember one, you remember the other, or you can work it through in your brain backwards. Amazing. So hemolytic disease of the fetus and newborn, so HDFN. Basically, it's a jaundiced baby, and it happens occasionally, well, very rarely with ABO incompatibility, but mainly it's due to Rh blood group incompatibility between the mother and the child. So the mother will be Rhesus blood group D negative, and then the baby will be Rhesus group positive. And that means that the baby has the antigen, so positive blood cells, and the mum doesn't. So remember, it's not in the first pregnancy because we aren't born with antibodies if we're negative. So in the first pregnancy, the child, because the mother's exposed to the antigens from the child, she'll make lots of antibodies, basically to attack her child. But it's not going to present because it's only the first pregnancy, and that's when sensitization occurs. But in subsequent pregnancies, because the mother already has these antibodies, it's going to attack positive babies, essentially. So in order to prevent this, we give all unsensitized mothers anti-DIG, which removes the fetal red blood cells leaked into the maternal circulation. And you also give rhesus negative blood products in women of childbearing age, so that they don't essentially make the antibodies and it won't affect their future pregnancies. All right, that's done. Any questions so far? Nope. I'll carry on. Blood products. So these are what you can give to patients via IV. Often people might donate whole blood, but they can also donate platelets or plasma. So when you get whole blood, you don't always just give whole blood to the patient. You give what's needed. And so you can put it in a centrifuge. And what that means is they'll like spin. And then because the different cells are like different densities and things, they'll get split up into different layers. And so you can separate them. So that means that you can get products such as this, red cells, which are often leukocyte depleted, which I'll tell you a bit more about, which can last 42 days in the fridge. Fresh frozen plasma, which contains all plasma components. And the clotting factors are particularly helpful in that. So it can last 1 year in the freezer. You can get platelets. If people are platelet deficient, you can get cryoprecipitate, which is kind of like a part of fresh frozen plasma, but it only contains factor 813.2 and von Willebrand's factor. So all cellular products in Australia are leuko-reduced. So leuko for leukocytes, white blood cells, and reduced, so reduced in number. And that essentially prevents certain complications. Basically like transfusion reactions. And then you can get irradiated blood products. So that again prevents transfusion reactions, specifically transfusion-associated graft versus host disease. And that's when kind of your own immune system attacks the product. I don't think this stuff is too important. So it's there, but you can read it. I wouldn't too much. All platelet products are irradiated because platelets don't have significant change, but like red blood cells and granulocytes could be changed and maybe damaged to shorten their shelf life or survival due to irradiation. Blood transfusions. So pre-transfusion, you need to identify the patient. You need to do an ABO and rhesus blood type for the donor and the patient. You need to do an antibody screen, and you need to do a cross match for fresh frozen plasma and packed red cells, so that there's no like overlapping antibodies and antigens, and so they don't get a reaction. And then you release blood from the transfusion. Make sure you ID the patient. Transfusing blood, consider if it's acute or chronic anemia. If it's chronic anemia, like we talked about before, due to all those causes, you treat the underlying cause. Unless it's very, very severe, you won't give blood by itself. If it's acute though, then it might be indicated because they're not going to be able to make so much blood in such a short amount of time. I wouldn't say this is super important. Yeah, I'm going to skip that. Cool. So complications, if you have a complication, then you need to stop the transfusion immediately. You leave the IV line in, you check for any errors, and often it's due to a different patient. So you've gotten the wrong patient, and then you complete the reaction form and things like that, get help from the registrar. You can get a couple of reactions, so we'll go through these 4. So acute hemolytic transfusion reactions don't happen very often. It's usually due to ABO incompatibility, so just different patient, wrong patient. That causes intravascular hemolysis, and that's important. And it happens less than 24 hours or less than within 1 day of the transfusion. They get fevers, chills, hypotension, things like that. And mortality or death is 10%. So quite serious. Delayed hemolytic transfusion reactions. So delayed, so it's 5 to 21 days post-transfusion. Get similar symptoms, but it's less severe. And that's due to extravascular hemolysis. So yeah, that's the main difference. Acute is intravascular because it's still in like your blood, whereas delayed is extravascular because the antibodies and stuff. Yeah, and so the red blood cells are actually lysed in the extravascular outside the blood vessel. Cool. You can get trali. I wouldn't say it's super important to remember all the details from it, but essentially you can know that after a blood transfusion, you can get like respiratory distress, and most of them will recover. And then you can get bacterial contamination. So the big thing about this one is platelets, because you store that at room temperature. Because it's at room temperature, then bugs and bacteria can grow, and symptoms happen during transfusion. So you get severe fever, rigors, hypotension. So these are symptoms of sepsis, or like, yeah, so infection of the blood, essentially. Cool. Done with that, we're on to platelets and clotting. So platelets come from megakaryocytes, which are produced in the bone marrow. They circulate for a few days and then they're destroyed in the reticular endothelial system or the spleen, and their main function is just clots. They also don't have nuclei, so both of these guys don't have nuclei. This is a big overview of how clotting works. Essentially, it involves these 3 big steps, and then primary and secondary hemostasis can be split into 3 more steps each. So firstly, you get injury to the to your blood vessel, which exposes a subendothelial matrix. So endothelium is your most inner layer of your blood vessel. So subendothelial is actually just one outside of that into the wall. In primary hemostasis, you have formation of a primary platelet plug. That happens via platelet adhesion, aggregation, and activation. And activation will essentially cause vasoconstriction. So you want it to constrict, essentially to make it thinner, or like make the opening narrower, so that it's easier for things to be stopped and form a clot. And it will also activate secondary hemostasis. And that's your coagulation cascade. And that will eventually form your stable hemostatic blood. So that's your big clot. And that happens via initiation, amplification, clot formation. So we'll go into a bit more detail now. This is primary hemostasis. So this is all the platelet stuff. So with platelet adhesion, you get injury to the endothelium, as we mentioned before, and that exposes the endothelial or subendothelial matrix, mainly consisting of collagen and tissue factor. And that has a high affinity for this thing called von Willebrand factor. And so your von Willebrand factor will stick to your endothelium or your matrix underneath the endothelium, and it will also bind to platelets. So it's kind of served as a glue between your platelet and your blood vessel wall, and hence that causes platelet adhesion. Platelet aggregation is when the platelets just kind of bind irreversibly, and then more and more platelets eventually join, and then you get platelet activation, and that releases thromboxane A2, which causes vasoconstriction and more platelet aggregation, and it also releases ADP, or adenosine diphosphate. The activated platelets will provide a negatively charged surface, which will help with assembly of the coagulation factors and hence promote secondary hemostasis. So two important things here, as I just mentioned, would be von Willebrand factor and thromboxane A2. I'd also remember ADP. I think it'll just come up as a little thing in a question. So von Willebrand factor, as I mentioned, has binding sites for collagen in the endothelial matrix and platelets. And it's also a carrier for clotting factor 8. And that's quite important because these things will often be interlinked. That means so you have a decrease in von Willebrand factor, you'll also get a decrease in factor 8. And then thromboxane A2, you might have come across before when you're studying like NSAIDs and things, because it's a prostaglandin. It vasoconstricts, mediates platelet aggregation, and it's inhibited by aspirin because that's a COX inhibitor. Cool. So these are your antiplatelets. Usually use antiplatelets to treat things like atherosclerosis and prevent it and things like that. Clopidogrel is used a lot. That's a P2Y12 antagonist. So that prevents platelet activation. Abciximab and tirofiban are glycoprotein 2B3A receptor antagonists. That prevents binding fibrinogen to platelets. And then aspirin is a COX inhibitor, so that reduces formation of thromboxane A2, prevents platelet aggregation. Yep, cool. So this is secondary hemostasis. So this is your clotting cascade. So first, for initiation, you have a breach of the endothelium, which exposes tissue factor, also factor 3, and that activates the extrinsic pathway, which is factor 7, and then allows that to come to the common pathway. And I'll go through the pathways in the next slide. Then you get amplification. Essentially, it goes all the way to 2, which is thrombin, and thrombin will then work to go back to the other factors and amplify it, and hence cascade, right? It gets bigger and bigger and bigger, and that produces more of itself via positive feedback because it just comes back around. And then clot formation happens because when enough thrombin is present, it allows fibrinogen to form fibrin, which can then form a clot. Important things in here would be clotting factors. So clotting factors were zymogens, and you cleave them to activate them and make them clotting factors. Vitamin K is required for 2, 7, 9, 10, so the TV channels, and all of them are made in the liver except for 3 and 8. Cofactors aren't catalytic, but they accelerate catalytic activity of other factors. And then calcium is required for a lot of things, and that comes into play a little bit later. So this is a a summary of secondary hemostasis. This is the way I remembered it. I feel like there are a lot of complicated diagrams, and this is a little bit easier. So what I did is I remembered 10, 2, and A because these are your common pathway and you're going to have to know these. And then essentially I just worked from 12, the highest one, down. So 12, 11, 10's already there, so skip that, 9, 8. And that's your intrinsic pathway. And then the only one left would be 7. So that would be your extrinsic pathway. And as you can see here is tissue factor. So that's factor 3. Yeah, so
another way to, if you're not really done, another way to do it, and this is not the way I did it, but this is cool when I heard of it. So if I get this wrong, that's why. But if you look at the intrinsic pathway and going through the whole thing, one of the ways to remember it is to look at the numbers and like the words. So 12 is what you start with, so you remember that one. And then the last letter in 12 is E, and then you have 11. The last letter of 11 is N, so you have 9. The last letter of 9 is 8, so you have the 8 here. The last letter of 8 is T, so 10 here. But then you can get my point. But this doesn't work for the next bit. But I mean, that's kind of one of the ways to work out the intrinsic pathway. So 12, 11, 9, 8, 10. And yeah, and then 2 and 1 also work, but just this bit doesn't work.
Makes sense.
But yeah, it's another way you can remember it if it helps you.
Yeah, it's a good one. Yeah, that's basically it. I think 5 is also here. They're kind of random. So like 8, 3, and 5 are kind of in the middle here. And then, yeah, I highlighted the ones with vitamin K derivatives. So they actually happen to be the ones in the middle, actually. And then you can see that lots of them require calcium. And you don't have to remember which ones exactly require calcium, but it's good to know that in general, in order to have a clot, you need calcium. So negative regulators, I think just know of them. So protein C, protein S, and antithrombin. Yeah, just know of them. Cool. Nice. Fibrinolysis. So that's your natural mechanism of clot removal, fibrinolysis. So lysing or destroying fibrin, which is your clot. These are some inhibitors of that. So plasminogen activator inhibitors and alpha-2 antiplasmin, alpha-2 macroglobulin. You can see it's kind of in the name because plasmin is actually the thing that allows this to work. And plasmin is created from plasminogen. And the things that help this happen is TPA, or tissue plasmin activator, and UPA, urokinase plasmin activator. Essentially, the products, you get FGDPs, or fibrinogen degradation products, and you FDPs, fibrin degradation products. Not too important. D-dimer is a big one because we can find that in a blood test. But yeah, that's basically it. These are some mediators. So these are drugs. Alteplase is your clot buster. So with an acute myocardial infarction, if that's within 12 hours, you can use Alteplase. And the way this works is it's just a recombinant TPA. And so what happens is, it basically works just like this. It creates more plasmin, which will then degrade the fibrin into your degradation products. And then tranexamic acid is an antifibrinolytic, and that inhibits plasmin. And because it inhibits plasmin, it's inhibiting this, that means you can't have this happen. And so you can use that short term to stop excessive bleeding, but it's not used very often, I don't think. Coagulation profile. So these are some of your blood tests you use to test for all of the things we just mentioned. And your APTT, or your activated partial thromboplastin time, measures your intrinsic pathway and your common pathway. And your PT, or prothrombin time, measures your extrinsic pathway and common pathway, and thrombin time is just TT, and that's your common pathway only. So the way I remember this is like the long one here, which is your intrinsic, is also the one with the long name, so APTT, and then your extrinsic, which is quite short, it's just your PT is shorter. Yeah, cool. You can do a mixing test, and that differentiates between a deficiency state or an inhibitor. And that's when you mix the patient's plasma, which you don't know whether they're coagulation or clotting factor deficient, with someone who's normal, like normal plasma. And if it's just a deficiency, the normal plasma will make up enough of the clotting factors that you get a normal clotting time. Whereas if they have an inhibitor that's inhibiting the action of their clotting factors, then even when you mix it with normal plasma and add more normal clotting factors, it's still going to be there and the time's still going to be long. So long APTTs, PTs, and TTs will mean that you have, you're having, I've had a total mind blank, sorry. You'll have a prolonged time if you have clotting issues. Yeah. And then you can also do an FVC, D-dimer, fibrinogen, platelet count, clotting factor levels, or clotting factor inhibitors, such as protein C, S, and antithrombin. And the way they do a lot of this is they mix the samples with sodium citrate, and that binds the calcium, prevents coagulation. And then calcium can be added to allow the coagulation to proceed. And then they time that. So the longer the time, the longer it takes for your clotting factors to work. And so that might be because you have a deficiency or an inhibitor. Cool. So interpretation, I would just remember this. This is kind of what I had in my notes. It kind of got me through. So if you have an abnormal APTT or a lengthened APTT, then you know it's something wrong with your intrinsic pathway. So it's going to be factor 8, 9, 11, or 12. If it's just PT, then you know it's extrinsic. So you know it's going to be factor 7. If it's both of these, then you know it's going to be the common pathway, because that's the only thing that overlaps in both of them. And then if it's all of them, then it's just you have issues with all of your factors, essentially. So these are your anticoagulants. You have short-term and long-term ones. Short-term, you only need to know heparin and low molecular weight heparin. And then long-term, know your warfarin and your DOACs, or direct oral anticoagulants. So you can get adverse effects with all of them. You can get bleeding, hemorrhage, bruising. Essentially, all of these are like bleeding, bleeding, bleeding. Epistaxis, nose bleeding, melena, GI bleeding. You can get hyperkalemia, and you can get thrombocytopenia because you're bleeding out. You need to know the antidotes. They often test you. So for heparin and low molecular weight heparin, you can give them Protamine. And then for warfarin, you can give them vitamin K, because that's a vitamin K inhibitor. So heparin is a naturally occurring molecule. How it works is it accelerates antithrombin 3, which inactivates 2, 9, 10, and 12. And it's given an acute treatment. It's safe for pregnant women. It's given IV only, and you can monitor it by APTT. Low molecular weight heparins, so enoxaparin, dalteparin, clexane, basically is chemical heparin again. It's just a degradation product. And it predominantly inactivates factor 10. It's given subcutaneously, so it's via needle. Has a greater bioavailability, a longer half-life, and can be used without monitoring. And so this is like kind of popular in the hospital, because even though you're in the hospital saying you can use the needle, but it works just a little bit better than heparin. It's a bit easier to use. Both of these are cleared renally. And then for warfarin, the method of action is it's a vitamin K competitive antagonist. And because you need vitamin K for 2, 7, 9, 10, that means you inhibit 2, 7, 9, and 10. So things can increase or decrease its sensitivity depending on how it affects vitamin K. I think the big one to know would probably be an increase in vitamin K intake via green vegetables will decrease its sensitivity, because it's trying to antagonize vitamin K, but you're just eating more. Liver disease can increase the sensitivity as well. Other than that, I don't think these are super important. It's contraindicated in alcoholism and pregnancy because it's teratogenic. So don't give warfarin in these two populations. Instead, I'd say go for enoxaparin. It's given orally, so that's a lot easier for long-term use. And then there's a delayed onset of action. And that's quite important because in the first 2 to 3 days, instead of being anticoagulant, so instead of being anti-clots, it's actually, it promotes clots. So what you do is use heparin as a stand-in. You give heparin until you know that the INR is right, and then you give warfarin. And you can monitor it via the INR. The INR is basically just a modified partial thrombin time, so PT. And then it's liver clearance. DOACs, or direct oral anticoagulants, is what they mostly use these days, especially apixaban, I'd say. And these are factor 10A inhibitors. The way I think some people remember that is that 10A, like X is apixaban, so things with X in it are 10A inhibitors. Yep, it's 30% renally cleared. Dabigatran isn't really used in Australia. I don't think it's that important, but it's a direct thrombin inhibitor, and there's 80% renal excretion, so they're kind of like, oh, what if they have renal disease? Like, use apixaban. It's also contraindicated in pregnancy, so yeah, and they don't require monitoring. They've got similar or better efficacy than warfarin. So they're your go-to long term. Cool. So what can go wrong with bleeding and clotting? You have too much clotting, you have too much bleeding. So with too much clotting, you need to know about DVTs, or deep vein thrombosis, PEs, or pulmonary embolism, and then you can have too much bleeding, so hemophilias, disseminated intravascular coagulation, and von Willebrand's disease. So deep vein thrombosis, that's when you get a big thrombus or a big clot in the body's large veins, usually your lower limbs, which can cause complete or partial occlusion. And how it presents is a unilateral, but it can be bilateral if you have it in both legs, unlikely, blockage. So that causes swelling, edema, pain, redness, and warmth. The main complication is pulmonary embolism, and that's when the clot dislodges, goes all the way up through your IVC, into your heart, and then into your lungs, and then it blocks your pulmonary arteries. Diagnosis is 3-step. You do a Wells score, and that's a risk score. A D-dimer if it's unlikely. And the thing with D-dimer is it rules out if it's negative, but if it's positive, then you don't know what it is. And that's because it's sensitive. So if it's there, it'll be positive, but it's not specific. And so if it's, it's not going to tell you what exactly it is. So yeah, if you don't have it, it's unlikely that your D-dimer will be positive. Yeah. And then your Doppler ultrasound will show, that's basically an ultrasound with the blood flow. So you can see the blood flow and it'll stop there. And then management, you have anticoagulants. So mainly just apixaban. You give apixaban for most of them, unless they can't. And then you give prevention. And that's because there are certain risk factors you need to know. So the big ones, Virchow's triad, surgery, because they're there, stasis, that's a big one. Cancer, which is part of hypercoagulability, the contraceptive pill, and pregnancy, again, hypercoagulability, genetic, so things like factor V lead-in, protein CNS deficiency, antithrombin deficiency, and then vascular injury. So if they've had like a prior DVT or PE, it can damage the blood vessels, and then like fractures, surgery, trauma, things like that. So PE is usually due to a DVT, so it goes up and then it blocks one of these vessels here. Presents with sudden sharp chest pain. So if you get a patient with sudden sharp chest pain, you're thinking PE as one of your major differentials. Because it's blocking a pulmonary artery, means blood can't get to certain parts of your lungs, and that's why you get tachycardia, tachypnea, you get sweating anxiety, dyspnea because they're not breathing well. And it's diagnosed similarly, so modified Wells score instead of a Wells score, a D-dimer will rule out, and then imaging. If there's high suspicion, you just go straight to imaging. So you do a CTPA, I think that's a CT, pulmonary angiogram. So that shows your blood vessels, and then you'll see a clot in there, essentially. Or you can do a VQ scan, or a ventilation perfusion scan, and that'll show a difference between the ventilation and the perfusion. You use that in pregnant people because you don't want radiation. And then treatment, short term, you can oxygen, heparin, thrombolysis, only if it's massive. And then long term, you can warfarin or pixaban, so like these long term anticoagulants. Those are your clotting disorders. These are your bleeding disorders. So hemophilia A and B. Oh, I'm not running well for time, am I? Hemophilia is when you have deficiency of a clotting factor. It's X-linked recessive and is often a new mutation. If you've got a deficiency in factor 8, it's hemophilia A. If it's factor 9, it's hemophilia B or Christmas disease. And then it can be severe, moderate, or mild. I don't think that's important. Essentially, presentation is just bleeding, bleeding, bleeding. So deep hemorrhage, deep bleeding, post-traumatic and post-operative bleeding, more bleeding, mucocutaneous bleeding. Hematomas is just like big blobs of blood, and then ecchymosis is like, yeah, bruising. Diagnostic tests, you do genetic tests, you do you do an APTT, PT, things like that. They would be prolonged. Factor 8 could be decreased because of hemophilia A. Von Willebrand factor will be normal because you've got nothing wrong with that. And that's to separate that with von Willebrand's disease later. Treatment is treat the acute bleeding, and then you give factor replacement, usually via some kind of plasma product. DIC is disseminated intravascular coagulation, and this was kind of difficult for me to grasp last year because you get more clotting and more bleeding at the same time. Essentially what's happened is because you get all these little like itsy bitsy tiny little clots everywhere, it means that all your clotting factors and your platelets and things are used up to make these things. And that's why, like, when you have like some injury elsewhere, these guys can't even reach them because you've used them all up, and so you end up bleeding a lot as well. So you have these microclots, and you have bleeding if you injure yourself. What do you need to know about it? I think you just have to know what it is. You can get prolonged in all your coagulation tests because you're deficient in all your factors. You can get a D-dimer increase because fibrinolysis is happening. Fibrinolysis is always kind of happening if you have clots. You can have a normal or decreased platelet count depending on how many are used up in here and how your bone marrow is tracking. And then you can have a decreased fibrinogen as well. Yep, so treat the underlying disorder causing DIC. It can be caused by a lot of things, and then replace the plasma platelets and clotting factors. Von Willebrand's disease is a common genetic disorder, appears in 1% of the population. It's autosomal dominant, and because it causes a deficiency in von Willebrand's factor, and I mentioned before that it is a carrier for factor 8, that means that it mimics hemophilia A. So you get a mild to moderate bleeding disorder. And it means that APTT is mildly prolonged because remember 8 was on the left for intrinsic for that pathway. And then you would do von Willebrand factor assays, and that means that factor 8 will decrease. Yep. Treatment is minimal. For heavy periods, you can get tranexamic acid. Yeah, again, you don't really have to know that. I think it's more important to just know what it is. Thrombocytopenia. So this is when you have too little platelets, be mild, moderate, severe again. You diagnose that via an FBE and confirm with a blood film. Etiology, I don't think you have to know this much about, but it's good to think it through via, again, increased destruction, decreased production, and then just like other. So splenomegaly is a big one, and that's because your spleen's so big, essentially it sequesters things. So all your platelets get trapped in your spleen, and you have thrombocytopenia elsewhere in your body. Yeah, I don't think any of these are super important for you guys to know, so skip. Thrombocytosis or thrombocythemia is when you have high platelets. You're going to have primary causes and secondary causes. So primary causes is myeloproliferative disorders, which just means that you're producing more because you just are. And essential thrombocytosis and a lot of the other cancers and similar things, which we'll cover tomorrow, can cause this. And then more commonly, it's reactive. So it's due to something that's happened. So if you've got inflammation, infections, malignancy, splenectomy, things like that, you'll have an increase in platelets. Yeah. Cool. Leukocytes. So they're white blood cells. They're for immune function. Again, like I mentioned before, lymphoid progenitors make your lymphocytes, so B and T cells, your NK cells, and your dendritic cells. And then everything else is formed by your myeloid progenitor. You can also sort them into granulocytes and agranulocytes. So granulocytes include your neutrophils, which undergo phagocytosis, so they eat up bugs and things. Your xenophils, which are active mast cells, and that's involved in the allergic reaction, as well as parasites. Basophils, also in allergy, and they also work as antigen-presenting cells. So you can see with granulocytes, they have these like granules and things, and that helps them destroy pathogens, essentially. Agranulocytes look a little different because they don't have granules. You have dendritic cells, which are your main antigen-presenting cell, and also a phagocyte, and that's how they present the antigen. You have mast cells, which release histamine, and that's why you take antihistamines for allergies. You have monocytes, which also phagocytose things. When they enter tissue, they become a macrophage. And then you have T lymphocytes, which can be CD4, CD8, or memory. CD4 T cells promote macrophages and activate B cells. CD8 or cytotoxic T cells target intracellular issues, so viruses and tumors. B lymphocytes can be plasma cells or memory cells. So plasma cells will secrete antibodies in adaptive immunity, and memory cells will essentially, with T lymphocytes, attack things that have attacked you before. What do they do in detail later? So abnormal leukocyte numbers, you can have leukocytosis, so cytosis for more and leuko for white cells. Usually it's reactive, so due to infection, inflammation, tissue damage, things like that. Infection's a big one because you need white cells to fight infection. Clonal is like in cancers and things. Leukopenia can be congenital or can be acquired. So like autoimmune diseases, drugs, infection, malignant, so like aplastic anemia, myelodysplasia, yeah. Abnormal eosinophil number. So you have more when you're having an allergic reaction, or you have parasites because that's what they're used for. And then eosinopenia, so less eosinophils, maybe due to steroid therapy. And steroids immunosuppress, so they're actually bringing down the number of all your white cells. And then basophilia can happen in things like CML, which we'll talk about later, and other allergic or inflammatory conditions. And then monocytes, yeah, they will increase with things like bacterial infections, chronic infections, inflammation. Again, so like infection because they're a white cell. Investigations, we're almost done. So you have an FE or an FVC, that's your full blood count. It's basically ordered for everything, and it gives you all these things. So basically the cell numbers for everything. Mean corpuscular volume, which I talked about before with anemia, is your average volume of a single red blood cell. So that should be, here it is, 80 to 100. Iron studies, so you have your serum iron, serum ferritin, so that's your storage in your body, mainly in liver and bone marrow. But yeah, so this is the main thing that people look at with iron depletion. And then you have transferrin for iron transport and transferrin saturation. So remember, when deficient, you have decrease, decrease, increase, decrease. Yeah, because there's less bound to transferrin, so there's more like free transferrin, so to speak. You can get a flow cytometry. That just means that basically they get a graph of this stuff, and you can see like how many of each cell there is. And then you can do cytogenics and molecular studies. Cytogenics are chromosomes, molecular is DNA. The dog's here. This is your hemolysis screen. So you can do an FVE, it'll show anemia. You can do a bilirubin, which will increase due to your heme. Your lactate dehydrogenase will increase as well. Your haptoglobin decreases because it's something that usually mops up free hemoglobin. You don't have that much free hemoglobin. And then your direct Coombs test will be positive. Your reticulocyte count will increase because your blood cells, have decreased. So you're like, oh, I've got to make more. So you have more immature ones, and then you have a normocytic anemia on blood film, or it'll show you the reason why. It'll show you like the weirdly shaped cells. So these are your blood film results. I took these straight in my notes, so they're not very pretty slides, but I thought they were informative. These are normal red cells. They look like this. They're round, pink. They've got a central pallor. They have no nucleus, and the size of them should be slightly smaller than a small lymphocyte. So that's there. So you can see that like they're all kind of a little bit smaller. So when they're bigger than a lymphocyte, that's when you're thinking, oh, it might be macrocytic. What are my causes for macrocytic anemia? These guys are reticulocytes. They look like red blood cells, but they haven't got that central pallor, and they're also larger. Usually it's normal to have a little bit, but they should be less than 1 to 2%. If there's more, then you're thinking, oh, why is there reticulocytosis? Yep. This is a hypochromic microcytic film. So you can see that like this is super thin. You compare it to like these guys, the edge is a little bit thicker than this one. That looks super thin. And so that's associated with decreased HB or hemoglobin concentration. So your hypochromic anemias. And then macrocytes are just large. I don't know, it's hard to tell. It's easier to tell in perspective. Polychromasia is when you have red cells of different colors, and you get that with reticulocytosis because they're slightly different color to red blood cells, like mature red blood cells. These are target cells. They look like a target. And you find that classically in liver disease, thalassemia. Spherocytes are these guys. Again, they don't have the central pallor, and they look a little bit like reticulocytes, except they'll all kind of be like this. And you see that in hereditary spherocytosis. It's a cause of hemolytic anemia. These are teardrop cells. You see it in thalassemia, but it's more classical in myelofibrosis. Myelofibrosis is like bone marrow fibrosis. And our heme tutor taught us that by saying like, teardrop cells when the bone marrow is crying. So if you see teardrop cells, it's bone marrow issues usually. Elliptocytes are ovals, or like they're also called pencil shell cells, classically seen in iron deficiency, but you can also see it in other things. It can be hereditary. Poikilocytosis is variation in shape, and anisocytosis is variation in size. Acanthocytes are these guys, so they're just like weird shapes. They've got spicules, and you see it post-splenectomy and in alcoholics. Stomatocytes have these slit-like pallor in the center, and that's due to alcoholic liver disease. And then Rolo formation are like these huge long chains of red blood cells, and they're in stacks. That's usually due to high molecular weight serum proteins in plasma, classically due to multiple myeloma and pregnancy, but you can also get it in other things. Autoagglutination looks like this. It's when all of your like blood cells are kind of stuck together, and it's due to the presence of autoagglutinins. I don't think you have to know too much about it other than to recognize it. Sickle cells, they look like sickles, indicate sickle cell anemia. Schistocytes are like these guys. They're like super fragmented, and it basically means hemolysis, right? Because they're fragmented means that the blood cells have been ripped apart. So things like MAHA, microangiopathic hemolytic anemias, again, you don't have to know too much about it, just recognize it. These are Haematology bodies, so little things inside. And the way to tell them apart from Heinz bodies is Heinz bodies tend to be like close to the edge, whereas these are right inside. These are normally removed by the spleen, so you find them post-splenectomy or if there's splenic atrophy, so small or no spleen. Heinz bodies and bite cells are for G6PD deficiency. Remember, Heinz, like beans, macrophages like yum, takes a bite out, becomes a bite cell. And these, like again, beans, broad beans, fava beans related to G6PD deficiencies. Basophilic stippling, like here, I don't know if you can see, it's a little bit small, but they've got little dots on them. Again, not really important, but they're just RNA remnants due to accelerated production or defective synthesis. So like thalassemia, lead poisoning. These are platelets. They're normal. These are normal platelets. They're small, they're itty bitty, pale blue cytoplasm. There's no nucleus. Yeah. And then these are neutrophils. So these are normal neutrophils. This is an edited image. So you're not actually going to get this many neutrophils. But you can see that they've got a multi-lobe nucleus, and that's how you identify them. There should be 3 to 5. Any more than that, and you're thinking megaloblastic issues. This is toxic granulation. So you can see the granules in the background here due to bacterial infection. So they have to make these granules because the bacteria is there. If they have intracytoplasmic inclusion, such as this, I don't know if you can see clearly, it's like a white thing. It's literally just like bacteria or fungi which have gone into the cell. Doll bodies, this blue thing here, also happens in like severe infection or sepsis. This is a hypersegmented neutrophil. So you see 1, 2, 3, 4, 5, 6, 7, 8, 9. Lots of nuclear segments. And that indicates megaloblastic anemia, basically. Other things can cause it. I'd say just know the anemia. Hyposegmented neutrophils can be benign, can be normal, or can be due to issues. Not that important. Normal eosinophils are classically bilobed, so that's a buzzword, and they can also come up on red-orange staining and have granules because they're granulocyte. And then basophils, your last granulocyte, just lots and lots and lots and lots of dark purple and blue granules. Monocytes, so your circulating macrophage, have your classical kidney nucleus. That's basically what you have to know about it. And then these are your lymphocytes, so your B and T cells. They just look like they have this huge like nucleus, and they can be small or large. Not too important to know the difference. A left shift, what they mean by that is basically, I don't know why they think moving to the left is immature, but it just means that there are less mature forms of everything. So you see more blasts, which are your immature white cells, you can see here, and they're just larger. And you also see, I think they're more referring to white blood cells with left shift. But yeah, it can be due to like bacterial infections because you're making more. Can be due to chronic myeloid leukemia because it's proliferation of these like immature cells. Hyposplenism has these cells come up, so you get target cells, you get Haematology bodies, this one, and then you have acanthocytes, this one with the spicules, and then spherocytes. Yeah. And then with bacterial infection, so you need more white cells, so you get neutrophilia. So increase in neutrophils, you get left shift because you're making more, so you have more immature ones, and you also have morphological changes in neutrophils. So here like toxic granulation, doll bodies, the blue thing, vacuolation, which is like forms this big vacuole looking thing. And you can also have intracellular or extracellular bacteria. this is a leukoerythroblastic blood film. So split that into smaller words. Leuko, white cells, erythro, red cells, blastic, so young cells. So young, white, and red blood cells. That's essentially what it looks like. It's a little bit hard to tell. I don't think you have to know too much about it. Happens in severe systemic illness and marrow infiltration, because if your marrow is going wrong, then you can't make these cells. Smear cells are classically due to chronic lymphocytic leukemia, which we'll cover tomorrow. They look like that. They look like smears. Oh, I think almost last slide, maybe last slide. This is a bone marrow biopsy. So these are performed at the iliac crest under local anesthetic like this. And you might do it for a lot of these things. Don't have to know too much about it. The main thing to know, I think, is know that this is normal. So it's normal to see some fat spaces, normal to see some hematopoietic tissue, and as well as some bone trabeculae. And in aplastic anemia, you see that you lose a lot of the hematopoietic tissue as well as the bone. And it's all been replaced with fat, which is why you can't produce cells and you get pancytopenia. That's it. Ooh. Okay, I'm going to stop recording